Hello everyone, and welcome to the 10th Talking Tuesday video series, where we review frequently asked questions and topics specific to health links and coordinated care plans. In this session, we'll be reviewing frequently asked questions related to approaching palliative care. The intent of the session is that you leave with an understanding of what a palliative approach to care is and what it is not. We will be discussing the tools and resources that are part of the provincial strategy to advance the Ontario Palliative Care Network Action Plan, and the hope is that this provides an understanding of how all of that aligns with the HealthLinks approach to care. Specific elements will include how to start serious illness conversations with patients and their families, and how to complete Appendix 4 of the Coordinated Care Plan itself. Our first frequently asked question is who should provide a palliative approach to care for complex individuals? So in order to understand who should provide a palliative approach to care for complex patients, we must first be able to understand what palliative care is and what palliative care is not. So palliative care is not something that is only provided by specialists at end of life. It is not a separate program or service. It really is an approach to care that addresses a patient's physical, psychosocial, social, spiritual, and practical needs and can be provided by any provider for a patient with a progressive, life-limiting illness. We recognize that currently, patients are often labeled as palliative and they'll be sent to palliative teams or specialists late and in crisis or decline. We do really advise against labeling a patient as palliative. Rather, the person is receiving palliative care or a palliative approach to their care. Palliative care is an umbrella term, and the end-of-life care is part of that palliative process. People who would benefit from a palliative approach to care are those with life-limiting progressive illnesses. These can be chronic diseases such as congenital heart failure, renal failure, COPD, progressing cancer diagnoses, etc. The Ontario Palliative Care Network has released the Health Service Delivery Framework, which is a best practice framework for delivering palliative care to adults in the community. This really speaks to a core team which involves primary care. It is supported by specialist services, and at times, care is shared with those specialists. Specialists can also include psychosocial clinicians, as well as bereavement and spiritual care clinicians or counselors. Continuing on answer who should provide a palliative approach to care, we will be addressing some of the myths. So one of the myths is palliative care is end-of-life care. Palliative care is an approach to care as mentioned, and it is not just for patients who are dying. A palliative approach means focusing on improving quality of life, as well as a holistic focus for those with life-limiting illnesses, regardless of the stage of illness that they are at. Early identification of patients and families who will benefit from a palliative approach to care have less emergency visits, they're able to cope better, and there are less complications with grief as well as bereavement. Continuing to address myths about palliative care. Another myth is treatment stops when palliative care starts. So you may think that palliative care signals the end of disease management and related treatment. But in reality, some disease-oriented treatments improve symptoms and really increase quality of life and therefore may continue to be provided as a comfort measure. The model beside outlines the focus of disease-modifying approach initially while including a palliative approach to care. Over time, as the chance of cure diminishes, there is an increased palliative approach focusing on the goals and wishes of that individual person. Our last myth about palliative care is raising the topic of palliative and end-of-life care diminishes hope. It is very important to have these discussions early to support a patient's quality of life as long as possible and really find out what is the most important to them, what is most meaningful to their life. Advanced care planning, or ACP, a process of communication that really encourages reflection on values, wishes, and goals. This is incapable of communicating their wishes related to care. The Serious Illness Conversation Guide. This is another tool to understand that when diagnosed with a serious life-limiting progressive disease, there will be decline, and what does the patient want as that happens with them? These discussions do not usually diminish hope, but shift it to a hope for comfort. There's dignity involved with that, and respect for a patient's expressed wishes. Also, it helps loved ones to be aware of a patient's preferences in the event that they do become palliative. Our second frequently asked question is, how do I have a conversation around palliative care with my clients? Are there any resources available to aid in starting a conversation with a client? So, a great place to start when having conversations with patients and their families regarding a palliative approach to care is the Gold Standards Framework and the Serious Illness Conversation Guide, as previously mentioned. The Gold Standards Framework is a tool which assists people in identifying patients that would benefit from a palliative approach to care earlier on in their disease trajectory. It is really applicable across all care settings and is disease agnostic as well. 3 trigger questions or themes are used with the Gold Standard Framework that will guide providers as to whether or not a patient could benefit from a palliative approach to care. Some of these questions are the first one, which is the surprise question. Would you be surprised if a patient were to die in the next year? The second one, general indicators of decline, so such as deterioration, advanced disease, decreased response to treatment, a choice for no further disease modification treatment. Under this section, you ask yourself questions such as, does this person have increasing needs? For example, they are unable to do so much for themselves as they were able to do 2 or 3 months ago. Are you anticipating the needs will increase? And lastly, specific clinical indicators related to certain conditions. Refer to the Gold Standards Framework for a list of these clinical indicators. We do only recommend using the third section if the clinical data will help the identification of a patient who will benefit from a palliative approach to care. And we don't recommend usually using it if you can't interpret the data or it will distract you from the identification process. So most people only need questions 1 and 2. The first question, that is the surprise question, can really act as the lead for most generalists. If you answer no to the question, would you be surprised if a patient died in the next year? It would be most appropriate to start considering, how will this person decline? What is likely to happen within the next few months? What do they know about their disease? Is it time to start planning conversations with the patient regarding how the disease may affect them? What are their goals and wishes and their goals? What are their expectations? Who is it that's important to them in their lives? Do they actually know their disease is progressive? All of these elements are a palliative approach to care. If you would like something a little bit more structured so that you can practice and standardize how to approach these situations, the Serious Illness Conversation Guide acts as a tool that anyone can use at any point in time. It has scripted, open-ended questions that can help guide these conversations for yourself. One of the most valuable questions that is included in the Serious Illness Conversation Guide is, what is your understanding now, and where are you with your illness? When you ask patients these questions, it can be a gateway to some very rich conversation. Following the prompted questions will assist all in becoming more comfortable having the serious illness conversations. The Ontario Palliative Care Network has recently released their Palliative Care Competency Framework, and this includes competencies for varying disciplines. Individuals can look at this document and search by their professor to ensure you have the knowledge, skill, and ability to deliver high-quality palliative care. The OPCN, or again, the Ontario Palliative Care Network, has also released the Health Service Delivery Framework. This is a best practice document for system-level organizations to really help them ensure that they are able to deliver high-quality palliative care. Our fourth frequently asked question is, how do I complete Appendix 4, which is the palliative care approach? This section is completed once you have established a therapeutic relationship with the client or the patient. It is important to consider when this should be completed. Also, just a reminder, this is not a checklist. It may not be appropriate to complete this in one sitting. There are several sensitive questions and conversations and should be asked with care and compassion. Ideally, you have completed the early identification, that is, you've asked yourself the surprise question to help you identify patients who would benefit from a palliative approach to care earlier on in the disease trajectory. The next step would be to consider what the person knows and is ready to know. Are you the right person to have a serious illness conversation with the patient and their family? Or is this best done with another provider who has a different relationship or competency? You may want to refer back to the OPCN competency framework if you require further competency development. Having these conversations with people doesn't come naturally to most. It really is a learned skill. You want to work through each section of the appendix via a series of questions and consider who would be the best person based on the patient's needs to ask some of these questions and at what point. Often we are asked, how do you approach or ask about specific or a preferred place of death? To have choice and control over where death occurs is considered central to a good death. In recognition of this, most end-of-life care strategies promote the need to support people to die in their place of choice and comfort. Current evidence suggests that when asked, the majority of people who choose home as their preferred place of death, PPOD in other words, with very few choosing to die in hospital or hospice. We know from research that patients want to have these conversations. However, they are willing to wait for their care team to initiate them. When asking a patient regarding their preferred place of death, a prompted question could look like, have you ever considered where you would like to die? Is it maybe in hospital, at home, or at a hospice? Try not to get fancy with your words, keep it factual and very short to the point. You will be very surprised how easy these conversations can actually go. And remember that as a person changes, their wishes may change as well. For each of the sections completed, review with the patient and their family. Ensure that other areas of the coordinated care plan are updated to include contact information for a patient's palliative care team. So this can include, for instance, the primary care team or specialist team. And if there are any gaps identified, ask yourself, who do I need to connect with? And connect the patient with the follow-ups regarding these specific situations. Our last frequently asked question is, where does mental health fit in with palliative approach to care? A palliative approach to care is disease agnostic, meaning anyone with a life-limiting diagnosis can receive a palliative approach to care. This should include those individuals with mental health illnesses as well. Similarly, you would ask yourself, would you be surprised if the patient were to die in the next year? If you do answer no to this question, the patient would benefit from a palliative approach to care. Next, you would start having the serious illness conversations and goals of the care conversations. Much of the palliative approach to care is about planning and really preparing for death. If a person is suicidal and you are able to have conversations with that person about what is most important to them, their legacy planning, etc., then proceed. However, when people are experiencing an acute mental health issue, we would encourage people to focus on that as a priority. This is a very nuanced component of palliative care, in particular bereavement needs, and we would be happy to support any team specifically with mental health and palliative care questions. So wrapping up, our key takeaways of the message are that palliative care is not something that is only provided by specialists at end of life. It is not a separate program or service. It is an approach to care that addresses a patient's physical, psychosocial, social, spiritual, and practical needs, and it can be provided by any provider for a patient with a progressive life-limiting illness. We do recognize that currently patients are often labeled as palliative and sent to palliative teams or specialists late and into crisis or decline. We advise against labeling a patient as palliative. Rather, the person is perceiving or receiving palliative care or a palliative approach to their care. Palliative care is an umbrella term, and end-of-life care is just a part of that palliative care. People who would benefit from a palliative approach to care are those with life-limiting progressive illnesses. These can be chronic diseases such as congestive heart failure, renal heart failure, COPD, progressing cancer diagnoses, and many other ones as well. The Ontario Palliative Care Network has released the Health Service Delivery Framework, which is a best practice framework for delivering palliative care to adults in the community. It really speaks to a core team which involves primary care, it's supported by specialist services, and at times care is shared with those specialists. Specialists can include psychosocial clinicians as well as bereavement and spiritual care clinicians. We've included embedded links to many of the resources and tools we've spoken about today. So although you can't click on any of these on your screen, we will include them in the link below the YouTube. And if you do require any further support, we recommend that you connect with the two contacts that we will provide on the separate page. So here are our 2 resources. Thank you very much for tuning into session 10, and we hope you enjoyed the session.